All right, so I think we're going to get started. Welcome, everyone. My name is Sarah Lawrence, and I'm an MPH student in the Department of Global Health and a Global WACh certificate student here at UW. Throughout my work in youth development as a school-based AmeriCorps volunteer in northern Minnesota and as a Peace Corps volunteer in Morocco, I have seen the importance of addressing gender-based violence as a key component of improving adolescent health. I'm very honored to introduce Dr. Avni Amin today on behalf of Global WACh, who will share her work spanning more than 20 years in reducing gender-based violence. She works as a technical officer at WHO's Department of Reproductive Health and Research in Geneva, where she oversees work on gender, gender-based violence, sexual health, and adolescence. She has led the publication of WHO's clinical guidelines on child and adolescent sexual abuse and WHO's Global Plan of Action on Violence Against Women and Girls and Against Children. Additionally, she has published on gender socialization and adolescence. Today, she will speak with an emphasis on both prevention and response among adolescent girls while examining the links between violence against women and sexual and reproductive health. Please join me in giving her a warm welcome.
Good morning, and it's a pleasure to be here. And just wanted to thank Global WACh, University of Washington, and particularly Dr. Donna Deno, Elizabeth, and Stephanie and Sarah for facilitating and organizing this session. I'm going to talk a little bit about the evidence and data that we have on violence against women and girls, and what we know about what works to prevent violence against women and girls, as well as to respond to it, particularly in the context of sexual and reproductive health programs. I'm going to take us through the slide set, but if people have questions, feel free to stop me in the middle and I can answer questions throughout. And then we'll leave some time afterwards for some more questions and discussions. So I'm going to cover 3 or 4 topics today. First is just to give you an overview of the magnitude or the prevalence of violence against women and girls globally. Talk a little bit about what we understand and know about the health consequences, as well as some of the other social consequences of gender-based violence. I'll then talk a little bit about the evidence and the emerging evidence on what works to prevent such violence, including among adolescent girls. And then finally, I'll talk about the health sector response and WHO guidelines for responding to violence against women and girls. So as some of you would know, violence against women takes many forms. Intimate partner violence, which includes physical, sexual, or psychological violence by a current or a former intimate partner, and in some settings it could be husband, in others it could be boyfriend or cohabitating partners. So what we know is that this is the most common form of violence that women face across the globe. Other forms of violence include sexual violence, that includes sexual harassment, rape, attempted rape, unwanted touching, coerced sex, forced sex. And this also occurs and has increased possibilities in situations of humanitarian settings as well as conflicts. The other forms of violence also include forced and early marriage, which many countries experience, and this is particularly prevalent among adolescent girls in many countries, including South Asia. In some settings, you have honor killings, and in some settings, that is about 29 countries in North Africa, the Middle East, and some parts of Africa where there's female genital mutilation. And then there's trafficking of girls and women in many settings. So in 2013, WHO published the first global and regional estimates of the prevalence of violence against women and its health effects. And this was part of the global burden of disease estimates, where we wanted to establish the extent to which violence, and particularly intimate partner violence, child sexual abuse, and non-partner sexual violence contributed to various health consequences. And this was published in collaboration with the London School of Hygiene and Tropical Medicine and with the South African Medical Research Council. At the time, we had data population-based prevalence survey data from about 80 countries. So I'm going to tell you a little bit about what the data showed. What we know is 30% of women aged 15 to 49 globally have experienced physical and or sexual violence by an intimate partner. Now these estimates vary somewhat across the regions, and here what I'm showing is the WHO region estimates. So for the WHO Africa region, the prevalence was about 36.6 or roughly 37%. Likewise for the WHO South Asia region, about 37%. In the WHO Eastern Mediterranean region, which covers parts of North Africa and the Middle East, it was 37%. And then countries in the Western Pacific, which is largely Japan and the Pacific Islands in Australia, we're looking at about 24.6 or roughly 25%. And then for countries in Latin America and Central America, it's about 30%. However, for a lot of people, what was also surprising is that countries that are high-income countries, the prevalence was not small or insignificant. It was about 23%. Then when you look at non-partner sexual violence, so violence, sexual violence, including rape and attempted rape by someone other than your intimate partner, you see the rates globally are about 7%. But I'm putting this out with a big caveat that data for this are much less widely available. So not many countries actually collect survey data on this form of violence, particularly because the levels of stigma are much higher. So in this case, what we see is globally the rate is 7%, but again, there is some variation. And you will see that even in high-income countries, this prevalence is around 12.6 or 13%. And the lowest prevalence rates were found in the WHO South Asia region and WHO Central Asia and Europe. If you then look at violence among adolescent girls, so 15 to 19, what you see is that this violence, particularly intimate partner violence, starts fairly young in the lives of women. So the prevalence globally for the age group 15 to 19 is about 30%. Again, with variation across WHO regions, and the highest prevalence is found in the WHO South Asia region, which is above 40%, and then followed by Africa, which is also roughly around 40%. Now, a lot of people think that pregnancy is a time when women might be less likely to experience violence. But the data actually show that this is not the case, that either violence continues, becomes more severe during pregnancy, or in some cases might start when women become pregnant. This is a qualitative data quote from a woman in Peru talking about her experience of experiencing violence when she was carrying twins. And you can see the quote for yourself, the consequences of such forms of violence, which resulted in miscarriage. So when you look at the prevalence rates, and this is based on the WHO multi-country study, which was carried out in 2005 among 10 countries, 24,000 women across the world, ranging from countries like Japan to Peru, you see the prevalence varies from around 1% in Japan to fairly high, well over 25% in Peru. This is prevalence, intimate partner violence prevalence in pregnant women. Other data since then show fairly comparable rates of violence during pregnancy. Now, what we also know is that when you look at clinical data, that is data collected from pregnant women attending antenatal care, those rates are much higher. And so in some settings like the Middle East or Africa, they are well over 30% in the clinical sample. So let's then look at some of the health effects of such violence. And here I'm going to focus on the pathways and the potential health effects of intimate partner violence. And there are three major potential pathways. The first is physical trauma, which results in injuries. And when WHO carried out systematic reviews of studies that looked at the health effects of intimate partner violence in terms of injuries, we found that globally across all the studies, 42% of women who had experienced intimate partner violence had experienced injuries, some form of injuries as a result. The second potential pathway is the psychological trauma and stress. And here there are several potential consequences. The first is related to mental health. And here what we found when we conducted systematic reviews, that women who had experienced intimate partner violence were twice as likely to experience depression. They were also likely to experience anxiety and stress-related disorders. Are you able to see?
Sorry, there's a problem with the recording, I guess.
Oh,
Not that recording, but the webcast.
oh, the webcast, okay. Should I continue or do you want me to stop?
Could I just check?
Sure.
Sorry. It should be capturing. Well, for Zoom, I have the computer audio on, so.
This is muted. So this
Oh,
has been
oh, so
muted.
this is what's not working?
Yeah, so is it flashing green? Yeah. You're good now.
Oh, thank you, Brandon. Thanks.
Okay, so as I was saying, the second potential pathway is through psychological trauma and stress. And here, depression is twice as likely to occur in women with intimate partner violence compared to those who don't experience. The other consequence is alcohol and other substance use disorders. So again, the data show almost twice as likely women who experience intimate partner violence are twice as likely to experience alcohol and substance use disorders compared to those who don't. And then we look at the impacts on sexual and reproductive health, and in this case, particularly maternal and child health. And what we found was that women who experience intimate partner violence are 16% more likely to experience or have babies with low birth weight. And I haven't shown the data, but we do have the data, 41% more likely to have preterm births. And the potential pathway here is several. One is trauma or physical trauma of experiencing violence during pregnancy. The other is chronic stress, which then causes intrauterine growth retardation. And in some cases, if there's extreme violence, you can have placental rupture. The next pathway is what we call fear and control, which limits reproductive control, decision-making control, use of contraception, and healthcare seeking. And here, what we find is that women who experience intimate partner violence are twice as likely to have an induced abortion. And for many countries where abortion is not readily available, it's often in conditions which are not safe for them. Sexually transmitted infections, including HIV, is another consequence of such violence. And what we found, data from sub-Saharan Africa particularly, is intimate partner violence is 1.5 times more likely to result in an HIV infection, as well as in other forms of other types of sexually transmitted infections such as chlamydia and gonorrhea. And then we look at mortality. So what we found when we did a systematic review of homicide data is that when you look at homicide data across the world, 38% of women who were murdered by their intimate partners. And this is in comparison to 6% of men who were murdered by their intimate partners. And the other mortality or potential mortality consequence is suicide or attempted suicide. And here again, linked to depression and alcohol and substance use disorders, we found that women who experienced partner violence were 4.5 times more likely to have attempted suicide. Some of the other consequences that are, for which we are getting increasing data now, we see that intimate partner violence, and this is a systematic review that was published in 2015, which shows a 53% reduction in the likelihood of using contraception, a 52% reduction in the likelihood of using condoms, and also 10% higher likelihood of child stunting. And we found the data, this is data analyzing DHS data from about 29 countries. And the potential sort of pathways for child stunting include limited autonomy of women to be able to take care of their kids, particularly those women who might have low levels of education. And the other potential explanation for child stunting is also through maternal depression, which we know is linked to a low birth weight and preterm births. Then we look at the issue of what violence does to the brain. And this is a brain scan of children who might have grown up in homes where their parents where there's parental intimate partner violence, or they themselves are exposed to what we call child maltreatment. And often they're fairly highly correlated. That is, that in homes where there's intimate partner violence, the children themselves might be getting abused. And here you see the effects on the brains of children because of toxic stress. And what we see is that excessive and repeated stress causing the release of chemicals that impair cell growth and that interfere with the formation of healthy neural circuits in the brain. It also results in a stress response that contributes to premature aging of the body. And you can see on the upper side a quote-unquote healthy brain, and in the bottom a brain of a child that's been abused. And you can see that the scan shows far fewer lit up areas, particularly in the prefrontal cortex lobe area compared to the healthy brain. That being said, there is hope. And the hope is that we know that violence is actually preventable. And in order to know how to prevent violence, we really have to understand what are the risk factors and what are the protective factors. So over the years, we have gained a fairly sophisticated understanding of the risk and protective factors. And we know that in order to understand what is the risk factor and protective factor, we have to look at the multiple levels of what we call the social ecology, which is risk factors that are at the individual, that occur within the context of the relationship, at the community level, and at the societal level. And at the individual level, one of the biggest risk factors is the history of violence in childhood. So both boys and girls who've experienced violence in childhood or who have been exposed to witnessing parental violence are more likely to experience violence, intimate partner violence, particularly girls who are more likely to experience IPV in their as they grow up, and boys who are more likely to perpetrate intimate partner violence if they've witnessed such violence, which really speaks to the idea that violence is a learned behavior. The second, yeah.
Sorry, could you explain how, like I understand how males might perpetrate, but how are you saying that females could end up in this situation?
It's basically the understanding that if you witnessed it, you think this is normal.
Okay.
And you are more likely to end up in those kinds of relationships where you're more likely to accept it. At the next level of the social ecology, when we look at risk factors, the one that stands out is male control over women. So where particularly you have men who are more likely to be controlling, so policing women's behaviors or girls' behaviors, wanting to know where they go, policing the cell phones, etc. Again, those are the relationships where intimate partner violence is more likely to occur. When we look at communities where violence is more likely to occur, you see that communities at the aggregate level, where both men and women say that violence is more acceptable, that they condone violence and that they accept sort of certain types of unequal gender norms, are also communities where rates of intimate partner violence are higher. And then if you look at a broader societal level, and this is coming from a publication done by Laurie Heisey in the Lancet Global Health, where they looked at cross-country comparisons. What they found was, when you look at cross-country comparisons, where you have countries with higher rates of employment, female employment, and female education rates, those are the countries where IPV rates are much lower. So it again gives you a sense of what is some of the big underlying drivers of IPV, and we know that two risk factors particularly stand out. One is what we call at an aggregate level gender inequality, which manifests in different ways, and the other is a history of violence in childhood. So you begin to see the connections between preventing childhood abuse, including violence amongst adolescents, as well as addressing some of the key gender issues that are driving this epidemic. So what do we know then about prevention? And in the last 10 to 12 years, there has been a lot of innovation and experimentation to implement programs to prevent violence and then to evaluate them. And this is a body of evidence that is really emerging. And in the next year or two, thanks to some big investments by donors such as DFID, who have invested 25 million in research on preventing violence against women, we're likely to see much more robust evidence on what works to prevent violence against women. And what we see is there's a slightly different pattern of what works in high-income countries and in low-income countries. And this is based on an analysis, on a systematic review of evidence on prevention of violence against women that was published in a special issue of the Lancet on violence against women in 2014. And I've left, I think, a copy of it with Sarah and Stephanie. And in the high-income countries, what we found, and this is the work by Mary Ellsberg at the George Washington Institute, Global Women's Institute at George Washington University, is that if you look at the promising interventions, they're the kinds of interventions that involve victim advocacy and home visitation and health worker outreach interventions implemented by nurses, and particularly focusing on parents to prevent child abuse, as well as trying to address intimate partner violence in those relationships. On the other hand, what is not effective is, and this is probably to be taken with a big caveat, that some of these were evaluated in isolation of other types of interventions. So justice and law enforcement interventions, and this is not to say they shouldn't exist, but simply that in and of themselves, they may not particularly be effective without other types of interventions in place. And then the other one that was not found to be effective in isolation, again, of other types of interventions, is simply having awareness-raising PSAs. So if you don't have other types of things that are in place to address violence prevention and you just have awareness-raising alone, it doesn't actually affect behaviors. In terms of conflicting ones, some of the perpetrator programs, so batterer interventions, and there are about 17 randomized controlled trials that show that batterer interventions don't seem to work, and it's largely because the batterer interventions focus on some of the more extreme perpetrators who are already in jails and have been court mandated to go into these battery prevention programs. And then school-based ones are conflicting in the sense that you have some interventions that work, such as dating violence prevention programs that have been implemented in the US, but there are others such as campus rape prevention or self-defense type of interventions that are not necessarily working across all settings. And I see two hands, so I'll stop here. Go ahead.
Could you kind of give an example of what victim advocacy would look like or what that means?
Yeah. Victim advocacy is usually within the health services or within any social services or shelter. You have a dedicated person who helps the survivor of violence to kind of, access shelters, access legal services, access counseling support or crisis counseling, and having somebody who actually helps the person navigate the systems and advocate on their behalf to access these services is called victim advocacy services. Yeah.
Yeah, kind of going off of that in regards to victim advocacy and as well as home visitation and health worker outreach, has there been any research done on whether or not the gender of the person who's helping, like if it's a female or a male who's doing the victim advocacy or who's doing the home visitation and health worker outreach, if that makes a difference? Like, is it more successful if they're a female?
Well, most of these by default, because most of the nurses are female, and their nurse-led interventions are female, so we don't really have the counterfactual if it would make a difference with men. And likewise for the victim advocacy, often people working in domestic violence shelters are female. So, yeah. Should I go on? Okay. So then I'm going to talk a little bit about what does the evidence say in low and middle income country settings. And in low and middle income country settings, you see a slightly different set of interventions that come out as being promising. And here, the three that are quite promising are community mobilization interventions to promote gender equitable norms, then empowerment training for women and girls, or empowerment training of both women and men. And then there are combined interventions that involve economic empowerment and what we call gender power training of women. And this is the economic empowerment could be a microfinance loan, it could be cash transfers, but usually it's combined with gender equality training. So just to kind of make that clear, you'll see in the upper side where it says conflicting, where it says economic empowerment alone or simply cash transfers or supplementary income ones alone by themselves may not work. And the reason for that is because in some settings, when you kind of introduce women who are not earning and you introduce them with cash transfers or economic, and they start earning money, it kind of disrupts the power balance in relationships and it might result in backlash. And it's not always the case, but there are specific settings where this happens and other settings where it doesn't happen. And that's why we've put economic empowerment interventions alone as conflicting, whereas the ones that are combined with more gender power training and working with both men and women are the ones that are more promising. And then again, what we see is that awareness raising campaigns alone. And I want to emphasize that because people often ask me, so does this mean we shouldn't do it? And what I say is that no, we can do it, but in and of itself alone, it won't work. So you always have to add other things in the mix. And then for things that we have insufficient evidence is things like women's police stations, social marketing programs, and one-stop crisis centers, which have been established in many low and middle income countries to provide legal, health, psychosocial support services in one place to women. And it's not that they don't work, we just don't know if they work or not as yet. Yeah.
This is super interesting. What would an empowerment training look like? And has there been data that shows us that maybe more like training provided by local people is more effective than training provided by, let's say, NGOs coming in and providing that, or are they similar?
So most of these, and the one that I will cite, which is now being replicated in several settings, is it's called IMAGE, which is Interventions for Microfinance and Gender Equity Training. And what they did was, this was implemented in South Africa and evaluated through a cluster randomized controlled trial. And what they did was essentially use a local NGO, local provider of microfinance services where women were coming to get microfinance loans. So you had groups, naturally occurring groups of women, where they then added a curriculum that was implemented by local NGOs on gender and power. So it was a lot more about building self-confidence, skills around negotiation, couple communication, and there's also, because you have groups of women, you also have this sense of sharing with each other tips, a sense of solidarity, a sense of safe space, a sense of community that these women felt when they were coming. So it was like a sort of, every time they came for a loan and or came back to repay the loan, which helped them materially, it also was a space where they learned certain skills that helped them in their interpersonal relationships within the household. And this trial is now being replicated in Tanzania and in Peru. Any other? Okay. So I'm going to go on. I just wanted to sort of talk a little bit about so this is the evidence that includes violence against women. There are also interventions that were aimed at girls. And then we subsequently, WHO and Institute for Reproductive Health at Georgetown, we specifically followed up with a specific review on intimate partner violence and sexual violence prevention among adolescent girls. And specifically for adolescent girls, what we saw was the importance and promising nature of parenting interventions. And here again, the nature of parenting interventions is really about helping parents communicate, but also reduce what we call corporal punishment. So where parents use violence to discipline their children, remembering again that violence is a learned behavior. So this was quite promising in different settings, and there are several curricula for that called Triple P and relationship counseling type of interventions that have been implemented largely in North America, so Canada and the US. And then the others were really looking at women, looking at children, both boys and girls, and adolescents who were exposed to child abuse or who were witnessing parental IPV, and giving them specific psychological support, so psychotherapeutic interventions and treatment for things like PTSD. School-based, again, as I said, mixed, and you can see a range of school-based ones where the dating violence ones in high-income countries were promising. Interventions in the low and middle-income countries where there was peer-based group learning around gender equitable norms was promising. And then the rape awareness, the self-defense training, and in some colleges you have confrontational rape prevention programs that don't seem to work. And then at the community level, again, community mobilization, working with adolescent boys and girls and other community members was also very promising, but this is largely being implemented in low and middle income country settings. And then finally, in low and middle income country settings where there's an emphasis on giving microfinance loans to help girls become more sort of entrepreneurial, the evidence is still kind of unclear as to whether it's working or not. Yeah.
So I know that recently there have been a lot of cases where children have been abused or such, but they're homeschooled, and there is no obviously schools have the support and third party. So what would you, or I guess is there evidence what is the best way to solve those kind of issues when those kids are kind of just at home and don't have a third party or someone else?
Those are one of the more difficult cases, because if you have children, and particularly if they're kept at home and there's no way for them to be seen by either child protection services or by other sort of types of services, then it's very difficult to pick up. The other option obviously is not everybody who's homeschooled is kept at home. So if the healthcare provider, if they're being taken for vaccinations, if they're taken for other child health issues, then you really could also potentially train healthcare providers to look for certain signs of abuse. And I can talk about it a little later in the health sector response, how you can kind of detect some of these things at a fairly early stage based on some signs and symptoms. So I just wanted to end this particular section about prevention by giving a sense of what we've learned from this sort of, collective body of evidence across both low and middle income countries and high income countries. And that is that there's really no magic pill, right? So one size fits all doesn't work, and one single isolated intervention implemented on its own is not likely to work. So what then works, and what are the characteristics of interventions that are more likely to work? And this is important because people tend to say, oh, okay, this worked in one setting, let's just replicate that. And sometimes replicating something that worked in one setting to another may not work. So what you have to think about is what are the key core elements of that particular intervention that are portable, right? So what we've learned is that interventions that work are the ones that are a little bit longer than 6 months, ideally longer, as long as possible. So not something that's 5 or 10 years, but at least we know now that within a period of 2 to 3 years, it's possible to change things. The second important thing that we've learned is that it's really important to work across sectors and to work at the multiple levels of the social ecology. So if you're changing relationship patterns and dynamics, then it's also important to work at the community level to change and reinforce positive norms, right? Because just simply working with individuals and couples when they are working in a context of where things how sort of norms and how couples are supposed to interact is considered normative may not really change the patterns and dynamics within the couple in and of itself. So again, just remembering that you have to intervene at multiple levels. The second thing is, the third thing that we are learning in terms of the characteristics of successful interventions is to really understand that fundamentally violence against women is about power. And so you really have to keep a critical reflection of how you use power in a positive and a negative way at the crux of the content and the curriculum that is implemented. And then the last thing is that we often say that while working with women alone is not sufficient, working with men in an isolation of working with women alone is also not successful. And so the ones that are successful are the ones that work with both, and largely that also have a community element where these norms are then reinforced in a positive way. Okay, so that's what we're learning about what is successful in prevention. Now I'm going to switch gears a little bit to talk about the health sector interventions, and some of these are and can be implemented through the health sector, but it's important to understand what the health sector can contribute to the prevention agenda. And for that, I'm going to talk a little bit about what we understand in epidemiology about the prevention continuum. And so you have primary prevention, which is prevention before something has happened, and then you have the secondary prevention and the tertiary prevention. And a lot of the health sector responses often lie in the realm of secondary prevention and tertiary prevention. So what does that mean? Secondary prevention is really once violence has occurred, you're trying to reduce the frequency and the severity. And tertiary is you're really just responding to mitigate the consequences of violence. And it's important to understand that none of these should be implemented mutually exclusive of one another, because you have countries where if you have a prevalence of 40 and 50%, significant proportion of your population is already exposed to intimate partner violence. So you actually have to do work early enough to prevent it from happening in the first place, but you also have to try and work with those who have already been exposed to violence and try to reduce the severity, frequency, and the consequences. So it's not an either or, but it's both. And that's where the health sector can play an important role in bridging this gap. And so some of the potential sort of pathways for the health sector to come in is and this, I'm taking a life course perspective, but it's in infancy. So and childhood, to really detect abuse occurring early in childhood and to address its consequences so that these children don't grow up learning and thinking this is normal. Then it is also to work at key transition points in people's lives. And often what we say is pregnancy, and particularly the first pregnancy, is a very critical window of opportunity, because that's the moment when parents are thinking about their nature of their relationship and dynamics change. They're also thinking about the child. So it's an opportunity to intervene with positive messages about prevention, both from within the couple, but also thinking about the well-being of the child and child abuse. So those are some of the sort of life course, what we call windows of opportunity for prevention. Then there's, of course, anybody who comes into the health facility, either for antenatal care, for family planning, with infections such as STIs and HIV, mental health conditions, where we know that these are risk factors for or indications that that intimate partner violence might be an underlying cause. So again, the encounter with the health provider becomes key, and an opportunity for the health provider to identify and then put them in contact with services such as legal, such as support, such as shelters, such as livelihood support, as well as to treat any health consequences and to connect them to psychosocial and psychological counseling interventions, as well as victim advocacy type of interventions. And then the tertiary one is, of course, just very much focused on the long-term consequences that somebody faces because of abuse, such as depression, anxiety, PTSD, any other mental health consequences that they may face. So that's sort of the interface between what the health sector can do, both to prevent as well as to address and mitigate some of the consequences. And they have a very critical role to play to connect these women to other services. And the reason we often emphasize health over some of the other services is because in low and middle income country settings, what women will tell you is they would prefer to talk to the healthcare provider about their problems and not necessarily go to the police, because the police is not their friend and they don't necessarily want their husbands to go to jail. They want the violence to stop. And so the healthcare provider's role becomes quite critical in such context. So with that in mind, WHO in 2013 produced clinical and policy guidelines for responding to intimate partner violence and sexual violence. And these guidelines cover about 6 areas, and they are based on a very extensive review of evidence. And that evidence is then subjected to what we call quality appraisal through methods such as GRADE. And then you have an expert group that looks at the evidence, looks at the quality of the evidence, as well as brings in more practical sort of expertise of their own to come up with recommendations for the world on what the health sector should do to respond to IPV and sexual violence. So these guidelines cover 6 sort of areas. And the first area that they cover and provide recommendations is what we call woman-centered care, or it's based on basic principles of psychological first aid, that every woman who discloses intimate partner violence should, at minimum, no matter what, in what setting, receive psychological first aid or what we call first-line support. And we've developed tools to help healthcare providers respond in this way, which is basic sort of listening, empathetic listening, validation, safety planning, and then linking the woman to the support services she needs. The second area that the guidelines cover is the identification of women who are experiencing intimate partner violence and the response to them. And here we cover things like victim advocacy interventions, empowerment counseling interventions that can be delivered in the healthcare facilities, as well as mental health support for long-term care. And what we say, the recommendation says, is that women should be identified through a process called clinical inquiry, not screening, but clinical inquiry. And then, where feasible, they should be given victim advocacy and empowerment counseling. And we recognize that the evidence for this is coming from high-income countries. So there are now trials being done in low-income country settings to see if these can be replicated in low-resource settings. The third area is clinical care for sexual assault survivors, and we've also recently added to this specific recommendations for children and adolescents who've experienced sexual abuse. And so these guidelines or these recommendations really talk about the basic package of post-rape care, which includes contraception, emergency contraception, PEP, presumptive treatment, and psychological first aid or first-line support. And any other mental health services that are needed over a longer period of time. And then the other set of recommendations are more at the policy level, which talk about training of healthcare providers, both at the level of medical schools, nursing schools, social work schools, as well as once the providers go out into practice, so in-service training. And then to really think about mandatory reporting, which in many countries is required by law, that doctors report the partner violence cases to police. But WHO actually has found that this is not necessarily helpful to women. And so we actually say don't have a mandatory reporting, but if women want to report their husbands or the situation to the police, then healthcare providers should offer to do it. Okay, so it's really driven by this idea that it's the woman's choice and autonomy and right and prerogative to determine whether she wants to go to the police or not. Now, having said what I said about the advocacy counseling and the empowerment counseling, and if you will recall just a minute ago, I said most of the interventions have been implemented in high-income settings. So we don't know what works in this particular area in low-resource settings. So with that in mind, WHO and the WACh Reproductive Health Institute in South Africa set up a randomized controlled trial in antenatal care clinics in South Africa to see whether a 2-session empowerment counseling was feasible, acceptable, and efficacious in reducing intimate partner violence. So this randomized controlled trial was in 4 antenatal care clinics in Johannesburg, and there were 2 sessions of empowerment counseling offered to pregnant women when they were coming in for antenatal care. And then women were followed up at the 6-week postpartum visit. And we also conducted research with the providers, with the clinicians, with the administrators in the clinics. And we did a process evaluation after the trial completed to see how the study participants and the healthcare providers felt about implementing this particular intervention. And the outcomes that we were trying to see is whether just 2 sessions of empowerment counseling delivered in antenatal care could primarily reduce the recurrence, frequency, and severity of partner violence, as well as improve health, mental health outcomes, self-efficacy, and help women access services, other types of support services in the community. And the findings that we found were very promising for us. We're still analyzing it, and we'll have a paper out pretty soon. But we found that just 2 sessions could significantly reduce intimate partner violence, particularly where the violence was minor and could sort of persuade the mother and the partner that it was in the best interests of the baby. So the very severe forms of violence which were linked to drinking of the partner, it was much more challenging to reduce that in a 2-session counseling intervention. But this is pretty important because you want something that is feasible to implement in low resource settings, and we found that is possible. I mean, just to sort of give you a sense that we saw a 48% reduction in intimate physical and or sexual violence just with this 2-session intervention. We saw that both anxiety and depression reduced in both the arms, but there wasn't much of a statistical difference. And then self-efficacy also improved, but again, there was no difference between the groups. And this is because the control arm had a standard intervention that had to be offered, which was connecting the women to the services. So in that case, that itself also was helpful. And then the safety behaviors went up marginally in both the groups. And what we are hypothesizing here is that this 2-session intervention improved couple communication, decision making, helped the women connect to the support services. There was also what we call diffusion effect. So the women were talking to each other about what was available. There was awareness raising of this, that this is an important issue for the health of the baby, and that women were more likely to disclose their experiences to their friends, to their family, and get a little bit of the informal support. And so these are some of the potential pathways by which it reduced the frequency of the violence. We found that the nurses who were implementing the intervention and the women found the intervention acceptable, that as I said, a 2-session intervention is feasible, but there are some concerns. And each session was about 30 minutes, which may be too much in some settings where you have antenatal care patients of like 100 patients or more a day. So even 30 minutes is quite a lot. And that you really do need dedicated staff counselors who will do this kind of counseling for 30 minutes, and they have to be extremely well trained. And so the Safe and Sound has a very, what we call a manualized curriculum to help with training and ongoing mentoring and supervision of the nurses, but you really do have to emphasize that. And then the importance of building referral networks with other services in the community also came through quite strongly. So what we've learned from this is that antenatal care is an important entry point for prevention, and that particularly because pregnancy is a crucial time for women to think about the impacts on their own health, their baby's health, and for their partners to think about the same, that it's a really important entry point for prevention, and that it's important to involve the administrators of the hospitals as well as the policymakers in a more cohesive and coherent response to this from the very beginning. So just to close off, I'll just talk a little bit about where we are in the political space with this issue. Is that we have the Sustainable Development Goals now, where gender equality is a specific goal, and within that there are targets to eliminate violence against women. And at the same time, within the World Health Assembly, which is the big governing body for WHO, where all the 193 ministers of health come, that there is a commitment from the ministries of health to implement a health systems response to violence against women. And this was through a global plan of action on health systems response to violence against women and children that was endorsed in May 2016. So we are monitoring the implementation of that plan, and we have to sort of get the member states, our countries and the ministers of health to report back on the progress they've made in the next 15 years. And finally, just to say, if people want some of the tools, they're available on our website. And we have a tool for medico-legal or forensic examination of survivors of sexual violence. We have a clinical handbook for healthcare providers on how to respond, and a handbook for management on how to respond to partner violence. And then finally, I told you about the first line support, and what we developed is a job aid, a very simple job aid with a mnemonic called Lives, to help providers think about first line support or psychological first aid in a very simple way. So listen empathetically, inquire what the woman wants, validate her experience non-judgmentally, enhance her safety, and connect her to social support. So Lives is what we ask all health providers when we do our training, to remember these 5 simple steps. And we've developed posters to help health providers just remember this every time they encounter a woman who's disclosing violence in a clinic setting, to, if nothing else, if just that much they can do, that's important in and of itself. And finally, I'll just close with this quote from a woman in El Salvador, that the doctor helped me feel better by saying I don't deserve this treatment, and that he helped me make a plan to leave the house the next time my husband came home drunk. And it's really very simple. Small changes can make a big difference. So I'll end here. Thank you. So we have about 10 more minutes for questions and comments and discussion. So we are in the process of compiling what is called a prevention framework, in which we will be looking at the body of evidence on social norm change or gender norm change, and look at all the interventions there. But I just wanted to sort of clarify that, you know, the body of evidence on this is still emerging. And when we develop guidelines, we have to really go through a very, very rigorous process of vetting the evidence and doing a critical appraisal of the quality. So we can't recommend something until we know that this is really, as a collective sort of body of evidence across countries, is working. So that being said, we can still say that these are promising interventions, and the social norm change one definitely comes up as one of the more promising ones.
I know this is like a really big umbrella question, but I think something that I learned in classes, like when, or like global mental health or the stigma, like how, when we talk about policy changes, and obviously you can't just, like you were saying, you can't just take care of the individual, you also have to make sure the community they are in, but how, like, how do you do that when there's so much stigma and it's like years of like just the dynamic of men being more powerful or whatever they say is acceptable? How do, I guess, like, how do you choose?
It's really one community at a time, and I'll give you an example that was implemented in Uganda, in Kampala, in about 8 districts, and it's called SASA, which is implemented by this NGO called Raising Voices, which is based in Uganda. And what they did was really work at the community level, and they had a very unique approach. One of the things they decided was to not have an approach that blamed anybody, but to talk about violence as something that people had control over changing in their own lives, in the lives of their partners, in their families, and in their communities. And they framed it as something that they said they had the power to change. And they used that framing of power to within. So I have the power to change my own behavior. I have the power to change, with other people, with my family members. And I have the power with other community members. And I have basically this idea of this collective action. And so when they implemented that in a very positive way, where it didn't blame anyone, what they found was there was less stigma for everyone involved, that it had an emotional connect and it resonated with people without making them feel defensive, and it gave them something of a hope that this is something they can do. And so what we're finding is that when you implement these programs and you're dealing with a lot of stigma and negative emotions, the best way to implement programs that can kind of transform that dynamic is to really frame it in the positive of what you can do to change this particular circumstance, both within your own family and within the community, and to get that sense of solidarity. Because for a lot of these communities that are very close-knit, it's not just about what's happening within their homes, but also a sense that they're now connected, and they're not alone, that they're connected with others in that same sort of spirit of, fighting something that's wrong in their community. Yeah.
So sort of in the same vein of you discussing, I think someone brought up the issue of children not being able to access programs because they were homeschooled. In a similar vein, I know there are lots of women who don't always have access to clinics for like antenatal care interventions. What's your guys' theoretical approach, or what ideas do you have about addressing the concerns of women who don't often have a contact to a health clinic or to like a public space like that?
So I can tell you the example of Afghanistan, where you can think about a context like Afghanistan, where prevalence is about 90% in terms of intimate partner violence, and women have extremely limited mobility. So they don't really go to health services for themselves. But there is one thing that women will go, even in Afghanistan, and that is for children's vaccination or children's health. And so we have been working with healthcare providers. The WHO has been working with the Ministry of Public Health to train healthcare providers to really work in contexts of child health programs, immunization programs, early childhood development, child nutrition programs, with the idea that the mothers will come for their children. So that is the point at which you actually find ways in which you get the women to talk about their experience. And also, when you see a child that's undernourished, that might have bruises, that might have specific developmental issues, a 9-year-old who's still bedwetting, or a situation where a child is constantly crying, anxious, and all of that. These are again also signs that there's something wrong both in the child's life as well as probably something happening within the family. And so it's also an opportunity both for the healthcare provider to identify the child and the mother to kind of ask questions about what might be happening, and then to kind of try and link them up to services. In India, when this particular domestic violence and sexual violence program was set up in a hospital, they very cleverly set up their clinic, the crisis counseling and intake sort of room. On one side was the antenatal care clinic, and the other side was the immunization clinic. And in between, they set it up, and the women, all the women were basically sitting out in the waiting room. On one side it was the women who were coming for antenatal, the other for the immunization. And they actually put the posters up that services for this issue was available. And so all women did was when they came, they would see, and this was this little discreet door, and there was always somebody, and so they would go knocking eventually. And then, when you get a good service in such settings, it spreads with the word of mouth, and it's very discreet, so nobody in the family needs to know that they've come to seek services for violence, because that is something that they don't want anybody to know. But they are going just to get antenatal care or to vaccinate their child. And that's how they're going to get this kind of care.
Thank you, and sorry for coming late. I was just going to draw a parallel to word of mouth, how important it is to the Tristan project in Senegal, and how women carried messages and then they took it to the community for more women in response to that. But then when you said it, I just thank you.
Sure.
You said when working in Afghanistan there was 90% prevalence of intimate partner violence.
Yeah.
I was wondering if you ever had issues getting some of the doctors on board with these programs, because while they are educated, they're also part of that cultural context that normifies that.
Yeah.
And how you overcome those barriers.
Yeah. So what I didn't quite give you the tiny little detail in the recommendations that we have for training healthcare providers is that training has two components. One is the clinical component, but also an attitudinal change component. And we recognize that you can't change people's attitudes overnight, so it's a process. So we have developed methods to address both, and in May of this year, or a little bit later than that, we're coming out with 2 curricula for healthcare providers, and this will be aimed at doctors, medicine students, nursing students, and midwifery students, and also for the in-service training, particularly ones who are already clinically practicing. And our curriculum will deal with some of the attitudinal components, where we kind of lead people through various exercises on sort of critical reflection of their own biases and values that affect caregiving. And then the clinical component, which is about how to ask or how to identify and recognize the clinical signs and symptoms, how to provide lives, and then the usual clinical care pieces. So we do address that, but it is a long-term process. And we found that the medical, nursing, and midwifery schools are a very good opportunity to start, because they're young, they want to learn, they're also open to thinking about these issues in a more flexible way compared to, say, somebody who's been in settings for a while. And the other way that we do it is often we just remind doctors that, regardless of their personal biases and values, that at the end they've all taken a Hippocratic oath, and so they have an obligation, regardless of whether they believe that this is something good or bad, that they ought to be able to at least treat and give sort of more empathetic treatment to women. And I can say we've done this with very senior OBGYNs from Syria, We've done this with very senior doctors in Afghanistan, in India, and it's you do encounter resistance, and you do. I mean, with the Syrian OBGYNs, the first question they asked me was like, so I want to understand what is marital rape and how does rape actually occur in marriage? And I said, well, this is what the global definition is, but I think you're better off just focusing on the fact that here's somebody who's traumatized, and regardless of your personal beliefs, let's think about what you can do as part of your treatment component. So to not make them feel defensive that their values or beliefs are wrong, but to put it within the context of how they can give the best possible clinical care. So, and we have we have a lot of clinicians who are now trained in these methods, who are now helping train other clinicians. So we do sort of think about, peer-to-peer trainings, and often that goes over much better than anybody else. But you can imagine that the training of Syrian OBGYNs, most of whom were much, much more senior than me and were heads of OBGYN department, was quite challenging. Yeah.
So this is the type of work that I would like to do moving forward in my career, and just wondering if you have any recommendations or suggestions for how I'm an MPH student might move into doing this work in a way that is, I guess, a sustainable and ethical model, either here in the U.S. or globally.
In the US, I mean, there's lots of organizations that work on violence, and the Futures Without Violence based in San Francisco does amazing work on violence prevention, both within the public health context, but more broadly. There are a lot of universities now doing research on violence prevention. I mean, I don't know about University of Washington, but I imagine that there must be faculty who are interested in that. And then there are a lot of other sort of NGOs that also work on violence prevention. The other sort of thing that I always give advice to all MPH students is just go out and go into the field, because that's where you kind of really learn the craft, so to speak, and you really get good exposure. So, yeah.
Okay, thank you. I think this will conclude the end of our talk. Thank you so much for spending some extra time here, and thank you very much, Dr. Amin, for speaking.
No problem.
This was
a pleasure.
Great presentation. So this presentation will be available on the WACh website. I will try to get it uploaded today, so it'll be available by the end of the day, or at least by tomorrow morning. And if anyone has any questions, can they email you?
They can email me, no problem.
So feel free to email her. And one